everybody. I would like to welcome you to the Master Class. This is our Vascular Ultrasound Master Class in the DEBAKEY Live series. Smoke alarm, that's not a good sign. But anyway, hopefully on the recording you will enjoy our lecture today. I would like to introduce my my guest speaker today, Dr. Peden, who is the Chief of the Vascular Surgery, but also the GC Rusty Walton number 3rd Centennial Chair in the DEBAKEY Heart and Vascular Center. If you have any questions, you can text DEBAKEY to the number 37607, or on the internet, you can go to the website pollev.com and just enter DEBAKEY and you can ask your questions. The recording will be available on our YouTube channel. And what I would like to do in my introduction is really teach you guys one of the valuable lessons I learned from Dr. Peden. When Dr. Peden called me and said, double check on this study. This is again an AVF study, and what I would like to show you is based on the values and the categories we have, the velocity did not triple, but Dr. Peden told me after the anastomosis you see the velocity expect to drop, and it didn't drop, and you see the anastomosis here. Oh, I don't see my arrow on the screen, but anyway, you see the first flow disturbance and the distal flow disturbance when we have the highest velocity measured, the 563. This is how we can see, and the confirmation on his angiogram, that you see that stenosis, and you see the where the flow disturbance is on my study. The second important lesson that I'm learning is that this is not a Pepsi Cola advertisement by any shape or form, but some people told us that they don't see PCA that often, but we do. For some reason, I think it's very important that you need to see the waveform. So on the right bottom corner, you see that typical waveform of the pseudo-aneurysm. But again, it's really interesting. On the left bottom corner, you see two different red and blue, but the PSA is on the bottom and just on the vein formation is on the top. But I believe that we definitely can learn a lot in AVF, and why we called the AVF and the Top Gun as a title, because we think without the ultrasound, without this finding, we won't be able to really take care of these AVF studies. And what I can show you is my prediction. So just looking at the subclavian waveform, and the normal high resistance waveform would tell me that the AVF is occluded. When I have a beautiful low resistance waveform, that it tells me that most likely my AVF is open. But when I have a delayed in an upstroke, that is pointing me maybe there is a proximal stenosis. So these are my main teaching point, and I just would like to direct you to our Vascular Ultrasound Master Class on demand. We're going to open up for our previous conferences, and you're able to see this recording. Dr. Peden, please teach us more skills, what we need to know about the ultrasound on these AVF studies.
Great. Well, thank you very much, Zsolt. Zsolt and I have been partners for a long time, and I think it's really important to collaborate with other people, particularly when taking care of these really sickly people. So I think that correlation between the ultrasound studies and then what happens clinically and what happens for other procedures are really important to take into consideration. So it's really important to have feedback, I think, to the vascular lab and the people doing the ultrasound studies to go over abnormal findings and not just discount them as misses. And that's the only way we learn and progress. And I got to say, when I go to the operating room and I don't find what I expected, I always go back and look at the ultrasound study again, because many times the ultrasound shows things that we don't see other places. But again, correlating between different imaging modalities, really helpful. We have lots of disclosures about people we work with and stuff, always looking for more. We feel very strongly that industry, physicians, and patients benefit when we have good interaction between the three. That's where our innovations come from. The patients and industry alike need clinical input from physicians, so we think that's really important. It just needs to be above board. So we'd say, well, dialysis access and vascular lab studies, like how hard could it be, right? These are pretty superficial structures. There's not a lot of breathing movement in between. You can see it, feel it, touch it, and you should, right? And talk to the people. Plenty of gel in the warmer, entry-level stuff like put the newbie on there, and how hard could it be? But yet, many people get this approach especially if they're asked for more than just is it open or is it thrombosed. But they really shouldn't, right? And there are lots of challenges to this. These are sickly people, sometimes pretty unhappy people, right? These folks have got a lot on their plate, medically, socially, and everything else involved. The anatomy is not normal, right? We've done some serious procedures and rearrangement of parts, which can lead to lots of strange findings, and there are lots of positive findings, right? Almost never are these like a negative DVT study, right? These almost always have something positive, and the question is what's going on? So why do we send people to the vascular lab, and what do we need back, right? So many times they go there before they've had to access creation, right? So they're preoperative mapping. That's really important. And I gotta say, I personally used to erroneously just call it vein mapping, but it's not just vein mapping, right? It's vessel mapping and looking for arterial disease, venous disease, central venous outflow obstructions. All those things can be so helpfully predicted in the vascular lab studies that are done beforehand. Determining maturation, right? This is ultimately the goal, is to be able to use these things and then figure out problems. So if all the fistulas look like this, a big juicy vein running right up the forearm that you couldn't miss, then this would be no problem. But sadly, that's not the way they all look, right? Many times they have arms that look like this with lots of scars, crisscrossing accesses, and the question is which one is supposed to be open? Is there more than one open? Is this a fistula or a graft or some kind of stent thing or some combination of all the above? And that can be really tricky, particularly depending on how long the person's been on dialysis and how many procedures they've had performed. I think really important to think about this, right? And the radiocephalic fistula remains the dominant fistula that should be created for people with dialysis access. And the outflow from the radiocephalic fistula is the thing that really determines what the longevity of this is. And you can see in the middle of the screen, it's the median antebrachial vein or the forearm cephalic vein that's coming straight up the middle of the forearm. It has three outflows. The upper arm cephalic, which is kind of the most obvious, is not actually the preferred, and that's through the median cephalic to the upper arm cephalic. The median cubital that dumps over into the basilic vein, that's actually the best outflow because it's usually the most wide open without other impingements. And then lastly, that perforating vein, which has gotten a lot of attention now in the last couple of years. But that perforating vein that actually reverses back down and goes down the deep system and then up and out the arm. So if all three are open, you've got lots of outflow, and likely this is going to be a fistula that lasts a long time. But increasingly, the dialysis population is shifting to older, sicker people that have had lots of procedures performed, etc. And these veins have been wiped out from needle sticks, IVs, etc. And many times are not there, and the only outflow might be through the perforator vein, which causes some unique problems. There's also lots of nerves in the area, right? So when people complain about hand pain and arm pain, it's not necessarily steel. Many times it's these nerves that kind of wrap all around the vessels or are there, they're getting trapped in the scar tissue from procedures that can lead to some of the symptoms and the complaints that people have. So just because they're having pain doesn't necessarily mean it's because of the vasculature. It could actually be because of the nerves. So mapping criteria have been set out for a long time, right? And really it comes down to a 2.5 millimeter vessel for a fistula, a 4 millimeter vessel for a graft that's predictive of maturation and good function, the absence of proximal arterial pressure differences, which is really important to think about, and their arterial lumen diameter of 2 millimeters or greater is really about radiocephalic fistulas. One thing that gets kind of forgotten about, including by me at times, has been the importance of the palmar arch. And if somebody only has a radial artery and doesn't have a good ulnar artery, or their arch is incomplete, then that can lead to steel or distal ischemia from radiocephalic fistulas, etc. And that's one of the biggest problems in dialysis is steel. So you need to really look at what's already in the arm and what's occluded. You need to note that on your study. That's really important. We definitely need a bilateral blood pressure, and yes, it does need to be bilateral, even if they have access in the other arm. We'll talk more about that as we go. Really look for arterial disease for us, commenting on how calcified the vessels are and whether they have significant stenoses or not. The deep venous status, really important. The central vein status, as best you can tell us. And then some sort of indication that the palmar arch is intact or incomplete. In terms of in terms of vessel mapping, percutaneous fistula is now firmly here. Those have been approved in the U.S. now for nearly 2 years and have really changed the needs of the preoperative mapping status, because now we need to know about the perforator vein, which previously was completely ignored because it played essentially no role in the preoperative planning by the vascular lab. We need to know about proximal arterial calcification and actually deep vein sizes for the radial veins, ulnar veins, and brachial veins, depending on which system you're using. This is one of the two systems. It's currently marketed by BD Medical, the Wavelink. And this system uses endovascular techniques, so catheters in both the artery and the vein, magnets to attract the two catheters together, and then uses RF energy to cut a path in between the artery and vein. There's no sealing, no suturing, etc. It's been approved in Europe for some time and is now approved here. And it's gone under different iteration and is currently under trial as a post-market study here in the US. And this really needs for the perforator to be intact, because you're going transvenous as well. We need to know about the size and quality of the deep veins, which previously was not important in mapping, but now is. So for this mapping protocol, you need to know about the size of the ulnar vein and radial vein near the wrist and near the antecubital region. The Ellipsis device is the other device that's been approved for this. This is marketed by Avenu, and this as well is a percutaneous procedure. It's a single catheter that punctures into the venous system, then traverses with a needle into the arterial system, and then essentially locks down at that area of transition from artery to vein, and then cuts a hole and seals the connection between the two. So this really needs not so much the deep venous structures to be identified, but definitely needs to know about the perforator vein, where it goes, what the quality of that is, and then what the artery next to it is looking like. And there needs to be a fairly small distance in between the radial vein and the radial artery so that it can seal properly. So here we're just going to look at the area of the antecubital region, and again, this is looking at the median antebrachial vein or the foramen cephalic vein, and we're looking for that perforator vein right there as it crossed the fascia and went down and joined. And this one we can see it's a nice big vein that crosses across. I'm just going to play that again. Whoop. So I'm going to go back to that. We're kind of looking right in this area as this vein is coming down and then joining the deep system. So right there where it crossed. So then you want to pause and measure that and see what that looks like. And you can see that it goes to the lateral radial vein, which is the common pattern. So after doing all this, obviously really important that you transmit that information to the people that need that are creating the access. We find a kind of a graph like this to be really helpful. Surgeons are very visual creatures, and seeing where those veins are and what the caliber of the vein is with the measurements out to the side is very helpful for us. We really like that. Another option is kind of like this, but I got to say having the numbers go right to it are really helpful. But the other things need to be included, right, is what's the proximal centrovenous structures like, right? Does the jugular vein open, subclavian, can you see it or not see it? Then you see the blood pressure measurements on there, which is really helpful, and then the size of the arteries. So the impact of vessel mapping has been significant, and this has been around for 20 years now. And what's been found is that the number of fistulas goes up, and in general, the maturation rates go up. So crazy helpful. This is one of the first ones that I got mapping on, and you can see the fistula here, but when we back out and look, and this is where the vascular lab actually marked it out, and this is back in the early days, they were putting X's and lines over where they are. This is not a vein that I was expecting to find, and a radiocephalic fistula is not an option, but this is an ulnar artery to sort of a tributary of the basilic vein that ran right over the forearm. I was expecting them to see this one on the back of the arm. That's the reason I sent them down, but in fact, when they found this one over the front, it was a much easier fistula to create, no transposition required, and using the size criteria and the patency of the vessels, was able to create a simple direct fistula and save the patient a bigger procedure than what was necessary. Again, all because of the mapping, and then turned into a good usable fistula. And that's the whole goal. For ones in the back of the forearm, we do need to move those to a usable area, and this is a long incision on the back of the arm. We get that vein, tie off the branches, and then swing over the front and connect it, because we want it in an accessible area that's usable. The arm heel is generally very nice. So why are we doing this study? Well, it's not just for billing, I'll tell you that. We're doing these because we have issues that we're trying to figure out, and that's what we want to know, right? So when people come in for some kind of problem type study, we really want for the documentation to be there. So it's really helpful when the people doing the studies will actually put on there, this is a problem with maturation, this is somebody with infiltration problems, low flow, alarming, they have steel, aneurysms, whatever the case is, to really document that. And here Victoria is one of our lab techs who's done this for us, and she's put on there previous procedures that have been done, why the person's there, and crazy helpful to have this when we come back to interpret the study and look at the values. Because it's really not just what you see on ultrasound, it's really not just what's going on with the patient's problems, but marriage of the two to see if we can connect and find fixable pathology that lets us get to the end goal of a good usable fistula without complications. So maturation, so the rule of the double, 666. So it needs to be 6 millimeters in size, it needs to be flowing at 600 cc's per minute to basically have adequate flow for dialysis, and it needs to be less than 6 millimeters from the skin. That's really important. Ultimately, then it comes down to us clinically, could we stick needles in this without ultrasound? Although some parts of the world use ultrasound routinely, that is not the case in the US. And essentially the dialysis technicians and nurses are on their own with their own wits and skill and fingers and eyes to try and stick needles into these fistulas. And you can help predict whether that's feasible or not. The real king and queen of maturation are size of the vein and how much flow is going through it. And ultimately, if it's big enough and has enough flow and they can get needles in it, then that's all good. Things that are not considered are depth and tortuosity. And those are two things that I think you should really look at when you're thinking about the study. So here we go with somebody who's getting their thing done. And this is one of the things that I think is most important, is a 2D grayscale sweep from the anastomotic area up to the next joint level, basically. So there we're looking at the anastomosis, we're following this fistula up, and what we can see is that there's some aneurysmal areas, and it's kind of diving back and forth and moving side to side on the screen. That just tells you this is a fairly tortuous fistula, and if it's deep in areas, that's going to be hard to hit. You can imagine that the more aneurysmal areas are the areas that they've been able to favor and find easily. But this 2D grayscale sweep from the anastomotic area up to the next joint, so whether that's from the wrist up to the elbow, from the elbow up to the shoulder, inside of the arm, whatever that is, that 2D scale sweep can really be informative in terms of what's going on. Here's another one as we're looking at it and seeing what's going on and where this fistula goes and how it drains, and we can see it's draining off into the basilic system, right? So the connection down here, a fairly aneurysmal fistula as it's sweeping up the forearm and then going across in the median cubital system and up to the upper arm basilic. So is it too deep, right? If it's deeper than it is big, then that's a problem, right? Because it needs to be accessible, and if it's too deep, then it's a real problem. There are some solutions. So again, kind of looking at this is when you're looking at the ultrasound scale, what I kind of look at in just a regular old ultrasound still image is, could I fit another fistula in between the fistula and the surface, right? So one in between there and the skin level. And if you can, that's probably too deep for them to use unless the fistula is just absolutely huge. So this is showing lipectomy, where basically we'll take some of the fatty tissue in between the skin and the fistula away so that it's more accessible and can be really helpful. It's done generally through a couple of transverse incisions. We'll isolate the fistula and take the fat out and close that up, and generally that can heal really nice, and then works for large arms as well, and just makes the fistulas much more accessible. And then here we've marked it in areas of tortuosity to try and help direct them in terms of where to puncture that. Previously we do these longer incisions, but those widen out and don't heal so well, so the lipectomy through transverse incisions or mobilization there we find to be really helpful. So when you're seeing aneurysms like this, that's a real problem, right? But the goal is not just to tell us there's an aneurysm there. We knew that before we sent them to the vascular lab. The question is, can you help us figure out why that is? When you see one like this with a scab on it, that's probably a time to call your medical director or referring physician or whoever to say, hey, we need this person taken care of, because if that scab comes off, that's a real problem. So again, don't just document it, help figure out why, right? So these aneurysms typically happen for a few reasons. One is excessive volume flow, and the other is outflow lesions. Those two things combined become a real problem, because bad things can happen. If you look at this and this, these are fistulas that are exploding or about to explode and can really be terrible. And these can lead to life-threatening hemorrhage, which is pretty dramatic. If you look at this, you're like, okay, it's a scab, but is it that bad? Well, it is that bad. I mean, look at that thing pulsate, right? And when we take this person to surgery, this little thin cap is the only thing separating 1,500 cc's of blood per minute from the ear. So if we're talking about outflow lesions, probably the most common problematic fistula for this is brachiocephalic fistulas. And where this fistula dives down through the upper arm cephalic vein, so-called cephalic arch or the cephalic axillary confluence, where it penetrates the clavicular-pectoral fascia, there's a terminal valve in the cephalic vein. That area doesn't dilate well, and that's most commonly the area that's a problem. Clinically, you can feel that by having a thrill over the sort of medial clavicle, or you can see it with ultrasound, etc. And there it is. It's kind of that tough fascia that it's having to penetrate through, and it is not dilated. In fact, has become increasingly sclerotic. This guy comes in with arm swelling. Looking at both arms, you can see, okay, that's a real problem. Why does that happen? It's not terrible text. It doesn't just happen as part of the thing. This fistula, in fact, is just way too deep. When we throw the ultrasound on there, we see it's a hematoma, not a pseudo-aneurysm, which is good. But again, this thing's nearly an inch deep, and that's a real problem. So you can imagine the techs are like this poor guy in the cartoon, of just chucking needles at the arm and seeing if they can hit the fistula. So you can help figure that out and keep this guy smiling by saying, hey, you know, this fistula is fairly deep. It's, you know, so many millimeters in size, but so many millimeters deep. Steel is, again, one of the biggest issues in dialysis. Maturation, I'd say, is one of the most common problems we face, but steel is one of the most dangerous problems we face because the consequences of this can really be terrible. When you're doing studies for steel, it's crucial that you're looking at the volume flow because high flow, low flow, adequate flow really determine what the clinical path is going to be and what the needs of the patients are. Again, confirmation of steel, because just because they have hand symptoms doesn't mean it's steel. Confirmation with digital amplitude change with AV compression. So not changes in velocity, not other things, but is the flow getting to the finger actually different with and without AV access compression? Really important. Looking for bilateral arterial blood pressures and arterial disease, really important. You say, whoa, how can you really take the blood pressure over that graft? But in fact, you can. So I'm not saying to do routine monitoring there, but I am saying that yes, you can do a diagnostic study and measure the blood pressure over this fistular graft at least one time. Short answer is yes, you can do it. Long answer is we've studied this. We've looked at over 200 steel studies where we did bilateral arm blood pressure measurements with no acute occlusions. So if this graft goes down after just doing the blood pressure up and one down one time, that graft is almost certainly head out anyway. And we don't want this. This is a claw hand from ischemic monomyelic neuropathy at a variety of steel that's really severe. You can see that they can lead to limb loss, which is really tragic, obviously. So volume flow, right? Going about the volume flow is crucial. This thing doesn't have to be perfect. It can be like my 10-year-old Jeep. As long as it gets us down the road, we're all good, right? But what's the flow in this thing, and is it getting adequate dialysis? A good 2D transverse sweep from the anastomosis along the outflow, I just can't tell you how important that is because it answers almost all questions. You can see shriveled up segments of this vein where it's sclerotic. You can see the aneurysms. You can see that it's crazy tortuous. You can see areas that are too deep. A lot of those things you can really tell. Reporting on the ratios is another thing that we really emphasize within our lab, because just telling me greater than 50% is probably not enough, right? Is this a ratio of 2.2 somewhere in the mid-body of the fistula? Or is this a ratio of 12.1 where we know that that's a really critical stenosis and is likely to make this thing fail? Again, you got to look back at the volume flow and what the clinical implication of that stenosis is it important or not? But seeing what that ratio is, you can actually grade it more so than just greater or less than 50%. Very helpful. Be systematic, standardize your approach, and it really simplifies how the study is done and interpretation of the study afterwards. And I got to say, talk to the patient. What's wrong? Why are you having this study today? Because that person probably knows, right? And then finding out what's going on with them will help direct you to the clinical issues. Could be a lump on the other side of the arm, could be hematoma, could be a swollen lymph node, could just be that they can't use this thing, could be that they're mad at their tech. Hard to say. But ask the tech what's wrong, ask the patient what's wrong, document that on the study, and that can really help direct us when we're doing the studies and then interpreting the findings. Because they don't have to be perfect, they just have to be good enough to get good dialysis. Thank you very much.
That was beautiful. I wanted to see if we have any questions. I would like to start, actually. Well, I don't see any questions. My first is, I understand that you will follow the still as a clinical symptom, but is there any flow volume when you're definitely interested in the still? When I see a flow volume of 2300, that kind of scares me when I know what's the cardiac output. What is the flow volume scares you that, oops, that's a little bit too much?
Yeah, it's a really controversial topic, actually, and there's been lots of studies done. Initially, everybody thought, wow, we're going to put all these people into high-output cardiac failure. The studies really have not shown that that's the case. That being said, it's intuitive that somebody with crazy high flows in their fistula are a problem. We know that also these people are accelerated risk for cardiovascular death, and we wonder if the changes in the myocardium in response to the high flow, plus the metabolic problems they already have because of their kidney failure, don't contribute to the fatal arrhythmias that kill many of these people. So I guess the shorter answer is I think that over 2 liters per minute, that's when I say, wow, that's a lot of flow. It's clearly way more than you need. And the problem is if you leave that for years, that's going to lead to a big engorged arterial and venous system that can give you real problems later. So the short answer is I think 2 liters per minute is clearly too much. We consider high flow to be something more than 1.5 liters per minute.
Cool. My other question is, do you have any different flow volume in the upper arm or lower extremity? Because I think when you run out of options and you don't have any options in the upper extremity, sometimes we see lower extremity AVF.
Yep. So the lower extremity AVF almost always are higher flow than the upper extremity just because of the size of the vessels. The requirements are the same. Really, they only need to be flowing at 600 cc's a minute or more. Clearly, those, because of the size of the vessels, almost always are flowing quite a bit more than that. But ideal is if they're flowing somewhere around 1 liter per minute or so is what I would think. For most arm accesses, if they're flowing somewhere around 800 cc's per minute, that's really the sweet spot. 1,000 is kind of an easier number to keep in your mind, but yeah, we try not to get it too excessive in the legs for sure. Because many of these people have PAD, circulatory problems in their legs lead to a disproportionate number of amputations that continue to happen to this day in dialysis patients.
My other question about your research activities, I remember a few years back we were working taking the entire team to do some screening cardiovascular risk factors in the dialysis unit. What did you learn from that research?
Yeah, it's interesting. So we did a big study where we went and surveyed dialysis patients at the units themselves. And we went and screened them for carotid disease, aneurysms of the aorta, and peripheral arterial disease, and also for neuropathy. So the incidence of carotid disease was not any higher than the general population. We screened over 300 people. The incidence of abdominal aortic aneurysm was very low, so it didn't really show that that was an issue. Peripheral arterial disease was high, as expected. Probably the most striking thing, though, was the incidence of neuropathy. So when we did neuropathic testing, even in non-diabetic people on dialysis, the incidence of neuropathy was exceedingly high. So lots of them with numb feet and all kinds of problems, which shows that the disproportionate amount of them having amputations is likely because of minor injuries that go unrecognized, and then their metabolic issues, calcified vessels, etc., that then lead to non-healing wounds and unfortunately limb loss for many people.
Well, congratulations for this work. My other question would be the pseudo-aneurysms. When I see pseudo-aneurysms, I'm always scared that it's going to rupture any moment, because for me it's almost like a contained rupturing. And if I'm a nurse in a unit, I don't have an ultrasound. I have no clue if there's a PSA sitting in the depth, and I'm going with my needles. What is the incidence of these pseudo-aneurysm rupturing, or so how dangerous they are? Because I showed you a really beautiful Pepsi Cola sign, and it looks really great on ultrasound, but for me it's looking extremely dangerous.
So I think the good news about pseudoaneurysms, and it was a really great study that you showed, right, is that those really aren't so dangerous. They're more symptomatic than they are dangerous. The ones that are dangerous are the aneurysms or pseudoaneurysms that are more superficial, with skin changes, particularly erosions or scabs, that are more likely to rupture. Those are the ones that can be really tragic in the outcomes. One of the most interesting things that people will say is, they're pulling clots, right? That's the report from the patient to the nurses. We're pulling clots or sucking clots out of this fistular graft. It must be clotted. And we look at it, looks like it's okay. It's a little bruised. We feel of it. It's got a thrill. We listen to it. It's got a bruit. We're like, it's not thrombosed. And we'll put the ultrasound on, and we can see there's actually no clot in the lumen. So it's always a big mystery. Why is this happening? Why are they pulling clots, right? What does that mean? Well, almost always what that means is that they've gone through the fistula, kind of like in the pseudo-aneurysm case you've seen. Now the needle's sitting outside of the access. It's bled back there, so there's blood. Generally that blood stops flowing, right, and creates a hematoma, and as they're going back on the syringe, they're actually sucking clots from the extravasation out through the needle and everything else. So there's not really thrombus inside of the access, but just some thrombus outside, just hematoma, which is what we hope that those pseudo-aneurysms turned into. So most of the time that's a success. And it really almost always means that they've just gone too deep. When the flow persists and they make the pseudo-aneurysm, it's generally not a dangerous thing, but sometimes what will happen is they'll keep doing that same thing. They'll increase the communication between the true lumen of the fistula and the false lumen of that pseudo-aneurysm, and suddenly then it just kind of, or over time, it just degenerates then and becoming an entire aneurysmal segment. There's a little plus side to that. It's now a big, juicy area of the access that's very easy for them to stick needles into. If it's not protruding through the skin, then it's not a problem. But the bigger thing is that it's obviously an abnormal flow pattern there, like your Pepsi Cola stuff, and is very prone to getting lots of mural thrombus in there. And then that can lead to issues then during thrombectomies and other procedures. But in terms of rupture, it's very unlikely to rupture deeper. When that does happen, it's almost always acute, and that can be a real problem because then it's almost always down to the deeper muscular compartments and can actually lead to compartment syndrome. Unusual problem to happen. When it happens, it can be pretty dramatic.
And my last question, when we see the reports, if I'm asking my sonographers, always see something inside your AVF. So when are you going to be scared and clean off some debris or clot from your AVF until you have a normal flow volume, let's see, 550? Do you touch them, or you will wait until they are 400?
Yeah, so do you mean that they're seeing debris within the lumen, or?
On ultrasound, we see that there's something inside the lumen.
Inside the lumen,
and we cannot tell you if it's clot or not, because those are the things that we just haven't done into pathology that much, but we know there's something sitting inside.
Yeah, so it's proposed that microemboli are probably a way of life for people on dialysis, right? They've got needles going in and out of their vessels. It's this high flow system that is prone to clotting and has other issues and that kind of stuff. And many times they're having little microemboli. It seems to be remarkably well tolerated by this patient population not to have an issue. I guess ultimately it comes down to, is this got enough flow that it's doing the job? It's routine now at dialysis centers for them to measure dialysis adequacy by what happens to the change in the electrolytes with dialysis. So they'll measure that at least once a month at almost every dialysis center in the US. So that can tell you about dialysis. And even a fistula that's flowing at 400 cc's per minute, if it's a smallish person, they're setting the machine at 250 or 300, that actually could be enough. And as long as they're getting down the road, that works. I've seen some really unique solutions where it's a low flow fistula, they'll put a tourniquet in between. So if the needle's down by the arterial thing, there's a tourniquet or something in between. The venous outflow is unencumbered because of the excess access above the tourniquet. And even with a low flow, they can get adequate dialysis. So again, if it's giving them enough dialysis, then that's okay. It is pretty frightening, I think, from the dialysis technician standpoint to see something waving inside of the fistula. As long as it's not a big chunk, then we think we're okay. If it's something small, usually that's debris or some intima, maybe a little bit of clot, or maybe a fibrin sheath from where the needle track actually was. And if it's small, what does that mean? Less than a centimeter or so, if I had to guess. Then that's usually not something that's a big problem. It's a huge mobile thrombus. That's something that's going to give you big trepidation like it would for a DVT studying the leg. Then that's when we get more excited and think about, at the very least, anticoagulation. Keep in mind, too, though, that these people at least 3 times a week, if they're on normal dialysis, are getting anticoagulated during dialysis. And many times, that little bit of anticoagulation, their platelet dysfunction that kind of prohibits clotting, and the flow through the access are enough to digest and dissolve minor thrombi that occur within the access. Because it's not like a low flow venous system where it's sitting behind a valve cusp and waiting to kind of propagate and create more clot.
And I know I said it's the last question, but I just have to ask one more, because you're on the spot, and this is where I really wanted to know. Do you have any tips, what we do when we have a graft scanning. So you do a graft when you don't have a fistula. I run into some issues that sometimes you do not see through the graft. Do you have any guidance where do you supposed to do a surveillance for the graft, or we just should make sure we don't do the mistake is like, oh, there's no flow in the graft. It doesn't mean there's no flow in the graft, but the scanning the graft. And after that, looks like we have one more question for you.
So early on when grafts are first implanted, and when I say grafts, I mean most PTFE grafts, so Gore-Tex grafts and that sort of thing, because there are biologic grafts and grafts made of other materials, but by far and away most of them are PTFE. The problem is, of course, scanning PTFE early after implantation is challenging because of the air that remains in between the nodules and the fibrils, right? So there's air trapped within the graft that takes up to 72 hours for that to resolve. And in that early period, you can be convinced that there's no flow because you can see it. You don't see a big air scatter or something like you would from calcium, and you see no flow within it, or you can't get a signal. That's usually not. So there, of course, checking the proximal artery, that's key, right? And when we talk about volume flow, there are labs that do it different ways across the country, but the most established way and most reproducible way to measure volume flow is in the proximal feeding artery, and not just right by the anastomosis because it's too turbulent there. So the feeding artery where the walls are parallel, the flow is pretty consistent, those are the areas where you're going to get your most reproducible volume flow numbers. Even so, we'd say to repeat that, right? And the standard is to repeat that to where you have 3 values, and you can look at those. If one of them is way off, then you should probably do one more, because you want 3 values that are fairly consistent. But looking at the feeding arterial flow, that can be really helpful. Obviously, a good 2D scan and sweep is really, really important. If it's early on, you're going to be very limited in terms of what you can achieve with the ultrasound probe, but later on you should be able to see it. Now, calcification and other problems can look at that, but I kind of think like the study you showed at the beginning where there were high flows and then not the expected low flow, that's another thing. So even if you can't see through that lesion, looking right after it and see what does the waveform look like and where the velocities, that can be really helpful.
So yes, thank you so much for watching online. I thought nobody's watching and everybody's scanning patients today, but looks like we have a live question on screening. How stenosis you consider significant and when to intervene?
Yeah, that's a great question, right? So if you're talking about screening before dialysis is created, finding stenoses beforehand can be really perplexing in terms of what to do with that. Because you might find arterial disease, you might find venous outflow disease. Definitely we want to know about anything within the body of the proposed vein that we're going to use as an access. Meaning that if you map out a beautiful cephalic vein in the upper arm and say that's going to be a nice brachiocephalic fistula, but there's a segment in the middle where it's become really sclerotic, and most commonly that's in an area of a valve, right where another tributary is about to join, very commonly about 2 to 3 centimeters above the elbow, and not something you see surgically at all. Really important to let us know about that. And more than a 50% reduction in diameter, that's really important to know about. So that's one of the things we look for. If there's significant arterial inflow disease, we really need to know about that, right? So comment on that in the reports area of in the findings area of the report, because we need for you to comment, because if we didn't look at the blood pressure numbers on there, we need for you to comment that there is a greater than 20 millimeter gradient between the arms, and if it's 60 or whatever that is, commenting on what that is, really helpful. For central venous pathology, that can be challenging for you to really quantify. You can look at the velocity shifts and ratios as you come through, and letting us know, again, that you've got a greater than 50% stenosis of the central venous outflow. That can be really helpful. Now that's before surgery. The more challenging to know is what to do with those numbers after surgery. So somebody comes in with an aneurysm and swollen arm and all these other things, and you do your duplex study, and you find a juxta-anastomotic stenosis with a ratio of 3.5, let's say, or 4, in a fistula that's being fed, but the volume flow is, say, 1600 cc's per minute, there's aneurysmal changes, etc., it can be easy to focus on that inflow stenosis, but in fact it doesn't need treatment and shouldn't be treated. It's actually hazardous to treat that because it's already fairly high flow. In the example I gave just now, 1600 cc's per minute, plenty of flow for them and their buddy at dialysis, right? Should be enough for 2 people. And it's leading to aneurysms and swelling. So treating that inflow stenosis actually should not be done. hopefully you can find during your study what the outflow problem is that's leading to the aneurysms and the swelling, and help direct therapies towards that. Because if people get excited about the inflow stenosis, that's going to be something that's not going to lead to treatments that are clinically meaningful. So I think it comes down to what's the clinical significance, and that's why putting that history and the story that's at the top of the report together with the findings and merging the two to say which ones of those findings are important is really helpful, right? And it's all about clinically driven findings and what to do about those for patient treatments. Because not every fistula is going to be perfect. In fact, none of them are, but they just have to be good enough to get them good dialysis.
Just going back to, because it was on the screening. So let's say that on my report, you're planning a non-dominant AV fistula. I'm reporting 50% brachial artery stenosis. Would you do anything on that stenosis, or you would consider the other arm? So what in the screening, so do you intervene? So I think that's why I wanted to spice that question a little bit, that
right.
How does it change your planning? Because I think this is where even you intervene, would you go for the other arm versus staying on the same arm?
I think there are a lot of times that in my particular practice I'll do additional imaging. And part of that's because many of the people that I get are not virginal to dialysis access or dialysis, have had lots of procedures done, have had many failures, etc., have had complications. So I'm pretty liberal with additional imaging studies. Obviously we live and die by the ultrasound, right? It's ultrasound, 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 almost like we say volume flow, volume flow, volume flow, right? And ultrasound from techs that really do a complete study to ultrasound in the hands of the surgeon that's going to be doing the procedures, a nephrologist or interventionalist that's trying to direct their therapy afterwards. Absolutely crucial. But there's other things, right? And with some of our studies, it's difficult to see the central venous structures, the proximal arterial disease, or the extent of arterial disease. So if somebody has significant arterial findings, I'm very likely to get invasive angiography prior to doing the procedure. There are some MRA studies and CTA studies that can be really nice, but I think for most people just go straight to invasive imaging. So if they have non-palpable pulses, significant calcification, we worry that shadowing from the calcification could be actually masking or hiding significant occlusive lesions. So if we can't feel pulses and you describe lots of arterial calcification, we're very likely to get arterial imaging first. Again, we still need that bilateral arm blood pressure is really important. And if they've had prolonged catheter dependence, any visible varicosities or swelling in the arm history and stuff, then we're very likely to get venous imaging with invasive venography first.
Cool. And I think just one more idea I had quickly about the venous side. So when we are mapping and I see a non-positive, almost continuous subclavian vein on one side, and I see a beautiful positive vein on the other side, does it scare you? Does it change your management or your planning?
It scares me a lot, or it should, right?
Because it's an indirect way. So I might not see the stenosis, but I have an indirect evidence that there's something sitting that we need to go after.
It is not to be ignored, I would say that, right? So these indirect findings are very important, right? Just like they are if you're considering iliofemoral venous disease. Because the problem is that although the arm's not swollen now, the arm currently at rest only has 50 to 100 cc's per minute flowing through it. When you attach this fistula and crank that up to a liter per minute, any of these outflow lesions that have been compensated for in the normal physiologic state are now going to become pathophysiology, right? And it's very likely to result in swelling, venous distension, and other problems. So you really need to watch out for that. So that would be one of the other reasons to say, hey, we should go on and get venography. If somebody's got a pacemaker on that side, I think that's really important as well to go and look carefully at those waveforms, because very commonly that's placed through the subclavian vein. We know the subclavian vein already has issues, and that plus the wires and then now flow from the fistula is very likely to exacerbate any pre-existing stenosis or lesion and result in venous hypertension of the arm, the chest, the face, wherever that problem may manifest.
And finally, I would like to ask you to please review this study with me. This is actually your first favorite scan. As you told us, you have your cross-section, and we are scanning first with the grayscale. Hopefully my second clip is going to be your colored. Hold on. Hopefully. I'm not going to give you too much hint, but
Yeah,
you will have
that's great.
you will have a feeling that this is how we started this lecture. This is going to be that stenosis.
Problems.
So this is where having again the cross section first.
Crazy helpful, right?
Yes.
So if you went back to your first one, what I noticed was there's a lot of calcium in the artery system, in the arterial system, right? That's one thing. When you looked at the area around the anastomosis, it almost looked like there might be something within the arterial lumen, and it could just be shadowing from the calcium. You also notice a few things, right? In terms of the technique, when I'm doing this with a trainee, what I'd actually like to see is more air space artifact on the sides. Right, so like there, on the sides, you have that air streaking, right, because of lack of contact. That's actually a good thing when you're scanning this in a small arm with a superficial vein, because if you have it like that, where you're seeing the whole thing, you're almost certainly pressing too hard. And you can see there that it's deforming and flattening the fistula. And to really get the best image of it, you'd like to not be flattening the fistula and show it in its round state, because the fistula doesn't live like this in the arm outside of you compressing on it. You could see a caliber change as you swept down towards the anastomotic area, right there, right? And that's small and thickened. And that's not so easy to appreciate in everybody on 2D or grayscale or B mode to see what the caliber of the vein is, but in this case you can see it. So that vein is definitely sclerotic and stenotic right near that area of connection. And the stenosis doesn't need to be just in the vein. It can be in the artery just as it's feeding, and it can be beyond that area, so not just right at the connection. The most common is that the anastomosis itself is okay, and it's a centimeter or so beyond that. In this case, it looks like it's right down by the area of connection.
Would you change the scale, the depth from 3 to 2, or you just want to zoom in this area?
Yeah, I think you could go more superficial, but I think in some of the machines that doesn't actually make it look any bigger, right? So it depends on what the settings on your machine are.
Okay. So this is my next run.
And I suspect that that's not real. I suspect that that's the person compressing it as they're sweeping over sort of the antecubital prominence, that area that it looks small is likely not a real thing, right? Because you're seeing, again, the full sweep across the entire thing, no air gap, so I suspect that you're compressing the fistula there. That's not a real outflow lesion.
And after few velocity measurement, for me, this is kind of low velocities, just to kind of give you a hint that we're definitely seeing higher velocities. And I think the hint from low velocities kind of give you a hint that your flow volume is going to be less than 600. So here's your flow volume, noticeable 234. And I think another guidance we need to emphasize that we do in our protocol 3 volume, and the 3 flow volume needs to be within 100. So if that's I think another way of controlling that. If your flow volume is, let's say, 200, 400, and 800, there's something wrong with the technique and the measurement spot. So this is where I want you to have at least those 3 measurement, but within 100 cc apart.
So definitely low flow, and you'd say, why is that, right? So I think we'd agree you have a nice sharp upstroke, so it's probably not arterial inflow disease. It looked like as you were scanning through there that there's some radial artery calcification. You wonder how much that's an issue, but then also almost certainly the anastomotic issues that we've seen before on the previous sweeps are probably related to the low flow. But that's definitely low, right? It'd be unlikely to get adequate dialysis through that. And you can imagine if it's that easy to compress as you're just sweeping the probe over the arm, how easy is that going to be to puncture inside of the lumen of the vessel and have the vessel stand up nicely? And it's one of the reasons that we say, especially early on, they need to put a tourniquet on when they're accessing the fistula, because we really want it to distend, right? Obviously during your vascular lab study you're not going to do that, but I'll tell you occasionally when we're doing our studies in the operating room, we will put a tourniquet on just for venous outflow compression to really try and make the vein more distended and turgid for puncture.
So here we are at anastomosis site, and one of my questions is, let's say that here's my stenosis. So with that stenosis, my previous slide would show a lower velocity, what we just had before, let's 140. Do you really skip, or you would compare the stenotic flow, the 563 to the 209, or versus the previous one, which was only 120?
Yeah, it's a great question, right? Because the problem is if you do it like we think about, that you do it sequentially, you're going to miss it. And the reason you miss it in this case is there's tandem lesions. So in this case, actually, you really actually need to go back to the normal arterial flow pattern and look at that peak systolic velocity just before the anastomosis and compare that to your 563 and not the 200 just before, because this does have serial lesions as shown on the confirming fistulogram. And you can sort of make that out looking at your flow disturbances on your color flow image.
Too bad my mouse is not showing up, but definitely you guys can see the two different aliasing on that color flow, and I think this is my favorite clip, how you really see that, and almost when you look at the ultrasound, it's perfectly matching your...
It is. It's striking. Yeah. It's a really gorgeous image.
While we're looking at this, we also received one more question. How does the amputation affect the flow on the heart?
Yeah, so amputation is obviously going to remove one of the limbs and is going to take out some of the flow. You're not going to see an appreciable difference in cardiac output, though, from single limb amputation. So the cardiac output should remain the same.
Thank you. And here's my flow disturbance. Usually I call it like an unorganized waveform when you see this. Too bad with our ultrasound we're really not recording these sounds, because I think it's hard to add those quickly sound to it, but I'm still waiting for that ultrasound machine which is going to give us that sound. But I think that when you see these waveforms, you really would like to hear that sound. Definitely the systolic upstroke is still there despite it behind that stenosis. That's for me one stunning.
That's interesting. Yep.
That is where, oh, now you're talking. Now your systolic upstroke is gone. So this is where, this is trying to organize the waveform.
Yeah.
So maybe this is like an unorganized waveform and we just a little bit of distal to it, but now your systolic upstroke is gone and your waveform is organized. So this is where these two images for me are really stunning, how we need to really learn how the organization of this waveform really happens.
So go back to your other one, to your last one. Yeah, so I think probably what we're seeing here is the jet through that stenosis is still hitting the area of the sample gate, and that's why you're still seeing that brisk upstroke. But when you move further beyond into, as you said, sort of the more organized flow pattern where it's become more quasi-laminar or whatnot, that's when you're seeing sort of the equaling out, and that in fact the inflow is blunted. And clearly it's going to be behind that stenosis. I think here you're probably just close enough to it, and I think that's the disturbance we see at the right side of the sample box. And
do you have any secrets about when your velocity like drops like half? Do you have any diagnostic value? Some of my sonographers would like to call it a 50% stenosis based on that when you have a flow drop as well. Not just when you have a velocity increase, but when you have a velocity drop. Well, you have to have them study that, because that's not the convention, right? The convention is really to look at the spike in the systolic velocity, not the drop afterwards. But it's intuitive that plays a role. I don't know that anybody's actually looked at that carefully. Well, this was our study, and thank you for helping me to interpret this, and thank you so much for your lecture and teaching us. I think when I'm interviewing my sonographer and coming out of school, looks like AVF is still with our TCD, the AVF is still there. That is really lack of experience, and I think this is where we really we have to continue to teach our sonographers and also our students. And I hope everybody can enjoy this recording. And thank you so much for the questions. I wouldn't believe anybody would join us live. Thank you again. Thank you.